Welcome to KJR SummaryCast. SummaryCast provides audio summaries of KJR articles created using an in-house AI tool with editorial or author review. For full details, please refer to the original article. Welcome to SummaryCast. Every clinical decision rests on a measurement, a number, a category, a rule. But what happens when the rules we use to measure success don't agree with each other?
That's the central tension in a new paper we're looking at today. It's titled Radiologic Response Assessment with RECIST 1.1 and mRECIST in Patients with Hepatocellular Carcinoma Treated with Atezolizumab plus Bevacizumab. It was published in a 2026 issue of the Korean Journal of Radiology.
Okay, let's break that down. The disease is hepatocellular carcinoma, or HCC, a major global health issue, and the treatment is a modern one.
It is Atezolizumab plus Bevacizumab, or Atezo-Bev for short. It's a first-line therapy that pairs immunotherapy, Atezolizumab, with an anti-angiogenic drug, Bevacizumab. It's a standard of care that's really changed the landscape from older treatments.
So it activates the immune system against the cancer while also choking off its blood supply. And the core of the paper is about how to measure if this powerful combination is actually working. We have two competing standards, RECIST 1.1 and mRECIST.
Exactly. At a high level, RECIST 1.1 is the workhorse for most solid tumors. It's straightforward. You find the target lesions and measure their longest diameter. Tumor shrinkage leads to a response classification, while significant growth is considered progressive disease.
It's a size-based metric, simple, reproducible. What about mRECIST?
mRECIST is modified RECIST, designed specifically for HCC. The liver is a highly vascular organ, and HCC is typically a hypervascular tumor. So instead of the whole tumor's size, mRECIST measures only the part that enhances with arterial contrast.
So it's not measuring the tumor's footprint, but its active or viable core, the part with the most aggressive blood supply.
That's a great way to put it. The theory is that for a treatment like Atezo-Bev, which directly attacks blood vessels, a tumor might lose its arterial enhancement, become necrotic or less active long before it actually shrinks in size. mRECIST is designed to pick up on that earlier, more nuanced signal of efficacy.
Makes sense. One rule is about anatomy, the other is about physiology. So which one is better? That's what the study is asking.
Precisely. Which one is more reliable for radiologists to use and, more importantly, which one does a better job of predicting what really matters, overall survival?
So how did they set up the experiment to find out?
This was a retrospective study from a large tertiary center, Asan Medical Center in Korea. They looked back at their database and found 207 patients with HCC who received this first-line Atezo-Bev treatment between June 2020 and December 2022.
What was the patient population like? Were they typical for advanced HCC?
Quite typical. The median age was 63, mostly men, which is common for HCC. A significant portion, about 18%, had more compromised liver function, Child-Pugh class B, and most, over 70%, had advanced BCLC stage C disease, so this wasn't an easy-to-treat population.
Okay, a real-world cohort. What were the key criteria for including a patient in this analysis?
This is a subtle but important detail. Patients had to have at least one hypervascular hepatic target lesion. In other words, a measurable tumor in the liver that lit up on the arterial phase of a CT or MRI scan.
That feels like it might tilt the scales. The study's authors even note the high exclusion rate. Out of 537 eligible patients, 330 were excluded. A huge chunk of those, 190 patients, were excluded because they didn't have a lesion that fit the mRECIST criteria.
That's a critical point for generalizability. It suggests mRECIST might not even be applicable to a large fraction of the HCC population, like those with infiltrative or hypovascular tumors. But for the cohort that was selected, the methodology is quite clean. They had two board-certified radiologists who were blinded to all clinical outcomes go back and independently reevaluate every scan for every patient.
Using both sets of rules?
Yes, for every scan, they assessed response according to RECIST 1.1 and then again according to mRECIST. This allows for a direct head-to-head comparison on the exact same imaging data.
And they were looking for two main things. First, reproducibility.
Right. Did the two radiologists tend to agree with each other more when using RECIST 1.1 versus mRECIST? They measured this using a statistic called Cohen's kappa.
And second, prognostic value. Which system's assessment, responder, non-responder, progressor, was more tightly linked to how long the patients actually survived?
Exactly. That's the clinical bottom line. The study population had a median overall survival of 10.7 months, so there was a clear outcome to measure against.
Okay, let's get to the results. First up, how many patients were classified as responders by each system? Did they get similar numbers?
Not even close. This was the first major finding. Using mRECIST, a striking 54.6% of patients were classified as responders.
More than half the cohort. That sounds like a home run for the therapy. Okay, and RECIST 1.1?
Only 16.9%.
Wow, that's a massive gap. More than a threefold difference. So by mRECIST's definition, the treatment looks far more effective. This has huge implications for clinical trials, where objective response rate is often a primary endpoint.
It absolutely does. You could report a 17% response rate or a 55% response rate for the same drug in the same patients just by changing your ruler. But this is where it gets complicated. Let's talk about the second outcome, inter-reader agreement.
Reproducibility. How consistent was the measurement?
RECIST 1.1 was excellent. It had a weighted kappa of 0.89. For context, a kappa of 1.0 is perfect agreement, so 0.89 is very, very reliable. Radiologists looking at the same scan will almost always come to the same conclusion.
And mRECIST?
It was what's considered substantial agreement, but it was clearly lower, with a kappa of 0.79. More importantly, the discordance rate was significantly higher. Readers disagreed on the overall response category in 14% of cases with mRECIST versus only 8% with RECIST 1.1.
That's not surprising, intuitively. Measuring the longest diameter of a mass seems more objective than trying to delineate the edges of a sometimes amorphous or regularly enhancing area, especially after treatment.
You nailed it. That subjectivity introduces variability, and that variability connects to another key finding, dissociated responses.
Define that term again. What does that mean in practice?
A dissociated response is when there's a mix of good news and bad news on the same scan. For example, the main target lesions are shrinking or losing enhancement, but at the same time, other non-target lesions are growing, or entirely new lesions are appearing.
It's a mixed message. It's like winning a battle, but losing the war. So which system saw more of this?
mRECIST, by a long shot. This occurred in 14% of patients evaluated with mRECIST, compared to only 4.3% with RECIST 1.1.
That's a non-trivial difference, and a major red flag. If a system is telling you the target lesions are responding, but the patient's overall disease burden is actually increasing, that can lead to dangerously wrong clinical decisions. You might keep a patient on a failing therapy.
Precisely. It suggests that a response based on enhancement alone in a few target lesions might not capture the full picture of what's happening with the disease systemically.
Okay, so to recap so far, mRECIST finds many more responders, but it's less reproducible and more likely to give a confusing mixed signal. This all leads to the big question. Which one is better at predicting survival?
Right. The researchers built statistical models to test this. Quantitatively, both systems were independently associated with overall survival, but the models that incorporated RECIST 1.1 consistently showed slightly better predictive performance.
What are the numbers on that?
They used a metric called the C-index, or concordance index. Higher is better. For predicting progression, the model with RECIST 1.1 had a C-index of 0.75. The model with mRECIST had a C-index of 0.70, a statistically significant difference.
So a definite, if modest, advantage for RECIST 1.1 in the models. But you said the survival curves were even more telling.
They are. The survival curve analyses, particularly in figures 4 and 5, really visualize the core finding. For RECIST 1.1, the curves are clean. The Kaplan-Reier analysis in figure 5 shows that the group of patients defined as responders has better survival than those with stable disease, which in turn have better survival than those with progressive disease. The lines are well separated and behave exactly as you'd expect.
A clear monotonic relationship. And the mRECIST curves?
They are much messier. And here's the most alarming part. The survival curve for the mRECIST responders actually crosses and dips below the curve for non-responders in the early months of treatment.
Wait, let's be very clear. The patients classified as responders had worse survival early on than the non-responders? That completely inverts the logic of a response criterion.
It does. It's a major anomaly. It strongly suggests that the responder category, according to mRECIST, is contaminated. It's grouping together patients who are having a true biological response with patients who are not actually doing well, likely those with those dissociated responses.
So the signal is just too noisy. It's picking up on a biological change, loss of enhancement, but that change doesn't reliably translate to a positive patient outcome.
That's the interpretation. The RECIST 1.1 signal, while identifying fewer responders, appears to be much more specific to true, durable clinical benefit. When RECIST 1.1 flags a patient as progressing, that has real clinical weight. For example, among patients that mRECIST called non-progressors, the ones who were simultaneously called progressors by RECIST 1.1 had a hazard ratio for death of 2.39, a much worse outcome.
Which brings us to the bottom line. What's the main takeaway for a radiologist reading these scans or a researcher designing a trial?
The evidence from this study strongly supports what updated European guidelines have already started to recommend. RECIST 1.1 should be considered the primary method for response assessment in clinical trials and, by extension, in clinical practice for HCC patients on Atezo-Bev.
That recommendation is pretty clear, but before we treat it as settled, what should we keep in mind about the study design?
The first caveat is built into the real-world design. The response assessments were retrospective, but actual treatment discontinuation was guided mainly by RECIST 1.1. So the study can show how each criterion was associated with survival, but it cannot fully tell us what would have happened if clinicians had continued therapy based on mRECIST instead.
So the comparison is informative, but not a randomized test of two management strategies.
Exactly. The authors also point out that many screened patients were excluded, most often because they did not have measurable intrahepatic target lesions by mRECIST. And because the included patients needed hypervascular liver targets, the cohort may have been enriched for tumors where devascularization was easier to detect.
Which could actually favor mRECIST response rates rather than penalize them.
Right. There were other practical limits, too. Patients needed at least one follow-up scan, so those with very early deterioration could be missed. And mRECIST depends heavily on arterial enhancement, so variation in CT versus MRI technique, contrast agent, and arterial phase timing can affect the measurement.
And the model statistics should be read carefully.
Yes, the C-index values describe the full multivariable models, not RECIST 1.1 and mRECIST in isolation. So the paper's strongest message is not that every number proves RECIST 1.1 is inherently superior, but that in this cohort it was more reproducible, less prone to dissociated response, and more cleanly linked to survival.
So the final verdict seems to be that while tumor biology is complex, sometimes the simplest ruler is the most effective, especially when consistency and a clear link to outcome are paramount.
It's a compelling argument for the enduring value of a well-established, if imperfect, standard. It's a very tidy and clinically relevant paper that provides clarity on a contentious issue.
That's our summary.
Until next time.